Without further ado, I've known Jeff for, God, Jeff, easily 10, 15 years. He came to Oregon and spoke at our conferences. He's an awesome speaker. He's the current uh, sitting president of the American College of Correctional Physicians. He just won the JNO Award, which is just an awesome award. I love Jay. And and so congratulations on that, Jeff. And I'm gonna turn it over to you to tell us more about what you've been up to and your talk about the verbal jujitsu, the art of avoiding confrontation. Good luck in correctional medicine.
Okay, so yeah, thanks everybody for attending. So this is something that I've kind of been working on ever since, even before I got into corrections. I started out as an emergency physician, and I'm going to bring this up later. Confrontations with patients and their families is not unheard of in emergency medicine either. I have kind of worked on ways that work for me to mitigate confrontation, and that's what I put it together and called it verbal jujitsu. Some people have asked me, why don't you call it verbal judo? Well, that's already taken. That book came out, and it actually is a little different than what this is. That book was written for patrol officers who want to make other people do something that they want them to do, like get out of the car, put your hands over your head, that sort of thing. So they're initiating the interaction. This is where the patient is initiating the interaction and how to handle that. So a little bit different. So I call it verbal jujitsu. I have no conflicts to declare, but warning, this presentation contains profanity. I am going to swear. So if that is a deal breaker for you, then you should log off now. Okay, but I suspect being correctional healthcare providers, you've heard it before. So
Hello.
Mute, please. Mute,
Yeah,
please.
come on in.
Mute.
okay, so the objective
Okay.
is this.
I make certain that I am on mute.
Okay, the objective is this. This is the headline of in one of my CME feeds that I get every day, and it said, relationships with patients may be the key to physician satisfaction, survey finds. And I think this is exactly right. I think that when physicians or medical personnel come to corrections and they don't make it, they burn out and leave, a good part of the time is because they can't make the bond with correctional patients. And that's what this is going to be about. So what kind of relationship do we want to have with our correctional patients? So this is our patients in jail or prison. Do we want them to be our friends? No, of course not. Do we want them to be our adversaries, like the guy you hate to see on your clinic list? No, we don't. What we want is we want them to be our patients. We want a doctor-patient relationship. We want them to accept us as their doctor, and they want us to provide excellent medical care. That's the goal. That's actually the same goal I had when I was an emergency physician. That's the same goal that any outside physician has. It's no different. That's what we want. Okay, so we're going to do two cases. We're going to talk about two cases, and then we'll have plenty of times for questions. So this is the first case, and I call this one the sullen man. So first of all, I should tell you that when I left emergency medicine to come into corrections, I did jails. I was asked by my local correctional or my local commissioners if I'd take over the local jail, and I did it grudgingly. but found out I really liked it. And so I transitioned over 10 years to jails. I also had some prison experience, but almost all of my experience interacting directly with patients is in jail. So this presentation is kind of jail centric, but I think it translates to prisons too. So the first case is a jail case. A newly arrested man with many medical problems is brought to your clinic. He's sullen, just sitting there sulking, and he refuses to answer your questions. So this is me. I don't have time for this. Stop being difficult. Answer my questions. Do it now. He says, you're not my doctor. Dr. Smith is my doctor. Me. I'm your doctor here. Where do you think you are? You're in jail. You don't give any choice about who you see. You see me. After some more back and forth like this, he yells, fuck you. He leaves. Me to the nurse. What an asshole. Okay, so.
This is real stuff.
Yes, so. So the first thing is, and this is kind of the first lesson of verbal jujitsu, is don't label your patients. Labeling your patient an asshole or a difficult patient implies that the patient is the reason for the confrontation and the disagreement. It implies something is wrong with the patient, not you. In actual fact, most of the time, we're the cause of the confrontation, either fully or partially. We need to own up to our own responsibility. Besides, I'm going to come back to that, but I also want to make a comment about inmate. One of the things that I still review charts, and I notice a lot of charting where the person refers to patients as inmate or I/M. So inmate says blah, or inmate complains of blah, or whatever. And they're not inmates to us, they're our patients. They may be inmates, but they're our patients. So I want you to think about my other life as an emergency physician. I actually saw incarcerated people there too. People would come to the ER. This is well before I practiced in a jail. They'd come to the ER and I would see them, they had belly pain, do they have appendicitis, or they have a blood alcohol of 3.5, and are they able to be incarcerated? And you know what? The nurses in the ER never wrote inmate in the charts. The doctors in the ER never wrote inmate in the chart, even though the patient was an inmate. Same patient, two different settings. They called them patients. So anyway, call them patients. Don't call them assholes either. Don't call them difficult patients. They're patients. And accept our own responsibility for the confrontation. So what I needed here, so in this particular, the confrontation with Sullen Man was totally my fault. It was not Sullen Man's fault. It was my fault because I didn't have any empathy. Empathy does not mean pity. Empathy is sort of the beginning of verbal jujitsu. Empathy doesn't mean, oh, yeah, I'm so sorry for you, you're in jail. Actually, a lot of people, I'm not sorry they're in jail. I'm glad they're in jail because that's where they need to be. But empathy means being able to put yourself in your patient's position and understand why they're doing what they're doing. So why was Sullen Man acting sullen in my clinic? Why was he? Well, maybe here's an answer. If I had checked, I would have known that Sullen Man, this is the first time he'd ever been arrested. Before Sullen Man saw me, he was arrested, handcuffed, hauled away in a police cruiser, had to maybe walk handcuffed in front of his family, friends, or coworkers. So he was humiliated. At the jail, never been to jail before, he was spread eagle searched, and you know how well they search. They actually pat down the bulbous naughty bits. He was fingerprinted. He had a mugshot taken. He had his clothes taken away. He was given jail clothes, including used underwear. Here, put on these used underwear. And then he was, because he had medical problems, he was told not asked, he was told, go to medical. He was thrown into a cinder block cell. It maybe stunk in jail. It was maybe cold. He might have been in the jail for hours. Maybe they made him take a lice shower. In the end, though, he was told to go to medical. He wasn't asked, he was told. So he goes to medical. So at the time he arrives at medical, before I've ever seen him, can we have empathy? Meaning, can we put ourselves in his shoes and say, what is this patient feeling right now? Once Sullen Man got to medical, what was he feeling? Well, no one up to this point, from the time he was arrested until he came to medical, no one had been nice to him. He was afraid I'd be mean to him too. And he was right, I was. Okay. He doesn't know me. I might not be competent. Everybody's heard about doctors who practice in jails and prisons. Why am I practicing in a jail? He was thinking, I don't want to see you. You're not my doctor. You don't know anything about my medical problems. Dr. Smith is my doctor, and he's been my doctor for 20 years. And what gives you the right to step in and be my doctor? Okay, this is all the stuff he was thinking. This is why he was sullen. This is why he didn't want to talk to me. Okay, so knowing that now, let's think about what I could do from a verbal jujitsu perspective to introduce myself and make this guy talk. Okay, so here, what do I need to turn Sullen Man into my patient, not just a patient, my patient, where we have a doctor-patient relationship? Well, first thing, I need to look like a doctor. When he walks into the room, his first glance at me needs to say, hey, that guy looks like a doctor. So I have seen clinical practitioners, both nurses and practitioners, who say, it's just a jail. I don't have to dress up. So they'll come in, I don't know, sandals. They'll wear a t-shirt. And you don't look like a doctor. So you're automatically feeding into his prejudice that you're not a good doctor, you're not a good medical provider. Second, I should not be afraid of him. So everyone else has been acted like he's got cooties. I should get close. This is my personal opinion. I start out behind a desk where in the jail where I usually practice, but it's the same in all the jails. And I have to come out from behind the computer. Usually I'll get within about 4 or 5 feet and look him in the eye, and I should greet him and introduce myself in the same way I would meet him in a clinic anywhere else as an emergency. Hi, I am Dr. Keller. I am glad to see you. You can say, I'm sorry you're in jail, but I am glad to see you. And I'm the doctor here at the jail, and my job is to work with your doctor and take care of you. So in other words, I need to explain to him how jail medical works. I'm not just going to just take over. I'm going to actually communicate with your doctor. I'm going to work with Dr. Smith, take care of you. My job is to take care of you in jail, and I'm going to do a good job of that. And I usually will say something along the lines, there aren't a lot of advantages to being in a jail, but one advantage there is that you have very easy access to medical, which means you and I are going to see each other. Since you have a lot of medical problems, you and I are going to see each other a lot. And we're going to talk a lot. This is just the first one. I'm going to get to know you, and it's going to take some time, but now, and the next thing I need to do is jail patients often incite emotions in us, not often, always. They always incite emotions with us. So, and we have to have the ability to turn that off, or at least not turn it off, but not show it. So if I feel revulsion, so I've got the person who, these are people I've actually had in my clinic, I've got the person who was abusing kids and filming it and putting it on the internet. I mean, as vile as you can get. He's my patient. I might be repulsed by him, but I can't show it. Flat affect. I had a patient who looked really clean cut guy, sitting in medical. I mean, he looked like he could be an LDS missionary or something. He looked really clean cut until he blinked. And the moment he blinked, on his eyelids was tattooed, "Fuck you." I mean, that's as antisocial as it gets. I mean, when he blinked at me, I went, "Whoa!" Can't show any emotion. Same thing for the guy that has swastikas on his forehead and lightning bolts on his or gang symbols on his neck. All of that. Some people, you just the hair stands up on the back of your head when you meet them. Can't show it. Can't look afraid. Some people you really genuinely like, can't show that either. You need to be always in a kind of a robotic, professional doctor-patient relationship and not show emotion. I've had people come in who smelled horrible because they were homeless, came into the jail, hadn't bathed, maybe were incontinent, can't say, ew. No, they're your patient. You can't do that. So I must suppress my emotions. I can't show it. If I do all of that, I can tell you from experience that it doesn't work all the time. It works 90% of the time. And the other thing that you can have in a jail or a prison is patience. You don't have to get all the way to a full doctor-patient relationship. Your patient might not trust you as a doctor the very first time he or she sees you, but you're going to see them a lot. And so by doing this sort of thing every time, you get there after a few visits. I've been able to do it almost every time. There have been some exceptions where that doesn't work out, but 95% of the time it works out. So these are the verbal jujitsu lessons from this interaction with the sullen man. Look and act the part, meet their expectation of what an excellent medical professional looks like and acts like. Treat them like any other patient. And as I said, when I transitioned from emergency medicine to jail medicine, for about 10 years, I did both. And it was kind of funny because I'd see someone in jail who I had seen the previous shift in the ER. "Oh, when did you get arrested?" "Yesterday." And then a week later, I'd see him in the ER again. "Oh, when did you get out of jail?" "Yesterday." So they're my patient either way. You treat them like a patient. Your interaction with them is like any other patient anywhere else. Don't label your patients. They're not inmates. They might be an inmate in a sense that that's a word that means that they're incarcerated. But to you, they're a patient. It doesn't matter whether that you're seeing them in a jail or if you're seeing them in the ER or if they've been transported outside the jail and are seeing an orthopedist, say. They're a patient to everybody. You don't write in the chart that they're an inmate. How you think and how you talk is how you'll act. And if you talk about them as assholes behind their back, as inmates behind your back, that's how you're going to act when they're in your presence. And then hide your emotions. If you feel revulsion, dislike, or even an attractive, don't show it. So those are the lessons from patient 1, the sullen man. All right, case 2. I think that actually before we do case 2, I'm going to go ahead and open it up for questions for 5 minutes if somebody has one. So I don't know if you're monitoring the chat, Mike.
Yeah, Dave was mentioning some stuff. I am monitoring the chat. And Dave Cundiff, a friend of ours, said that one of his techniques is to tell them that I'm not part of your punishment.
That's a good phrase. I like that.
Some patients actually do see us as part of their punishment, I suppose. Anyway, the best I just want to give you best care the best way that I can. So,
I think that
Dave, if you want to speak up for yourself, you can.
Let me comment on that. a lot of people on the outside think of correctional physicians that way. People, they say incarcerated people are in jails and prisons to be punished. And if you're in there with them, then you're part of the punishment. Anyway, yeah. But that's excellent, Dave. I like that. I might even use that. Oh,
I
I
had another.
agree. That's one of my pet peeves is they're not inmates, they're not offenders, they're patients, and it's much easier to type out patient than inmate or offender.
correct. Exactly, Kate. And if you say inmate, you think of them as an inmate and you act towards them as if you're an inmate or a correctional officer. You need to say patient and think of them as
Yeah.
patient.
Some people have started calling in the chart AIC, adult in custody, thinking that that's really cool compared to calling them an inmate. And I disagree with that so much because it gives you the right to still see them as other rather than your patient, And so the
Right.
verbiage is really, really important. And this inmate adult in custody business is not better. That's my
No,
opinion.
they're patients. Dave, you were going to say something else, I
I
think.
had a question, Jeff, and thank you. This is really cool stuff. I hope I can stay for most or all of it. Is the expected appearance in a correctional setting, is the expected experience for physicians and healthcare personnel changing? I'm now primarily in inpatient alcohol and drug rehab rather than in correctional settings, although we do share a significant number of patients with you guys. And I'm still investing in neckties and button-down shirts, but I've always said as soon as some other outfit shows equal respect, I'll go to something simpler. Is there any change that you see over the generations in what outfit, what clothing gets you the most respect?
Yeah, well, yeah. So this is just my come back to that. In the ER, everybody wears scrubs. You can't really wear scrubs. And so that, in the public mind, that looks kind of doctorish. And that's what they wear on the doctor shows. But you can't really do that in most jails and prisons because that's what the incarcerated people wear. So what I did, you can wear a white coat. A white coat has always been a symbol of being a doctor. That is a great way to just, whatever you're wearing underneath. I'm like you. I didn't wear a tie, but I always wore a button-down shirt and a suit coat, nice pants and shoes, and nice shoes. And that's what I wore. Sometimes I wore a white coat. But anyway, that's what I wore. So I think it might be changing, but people still are kind of in the Marcus Welby expectation of what a doctor should look like. So that's kind of what you should look like.
I always believed that a white coat was counterproductive, if only because it set up the authority thing, and as much as you want to assert your doctor, I did that in other ways besides wearing a white coat because I thought that would get in the way because so many of my patients would have problems with authority. It worked for me, but I can't disagree with anybody. As a matter of fact, I had plenty of people disagree with me not wearing a white coat.
I say something?
Sure. Steve, yes. Steve, by the way, I should tell you that Steve is, well, Mike too, but Steve is one of my heroes and mentors and is kind of who I wanted to be, except he's worked in prisons. Anyway, so whatever he says is going to be golden. So listen up.
Thanks an awful lot for that, Jeff. I think you said it very well, and that is you want to look like what they would expect a responsible, caring, acute physician to look like. I don't know whether a tie makes you that or a button-down shirt. I think it should be something you're comfortable wearing. But I think the point is you want to think of yourself and portray yourself as a professional physician. And that's what you have to carry off. And that's what you're trying to tell them. And that's what you really want to think of yourself as and that's your portrayal. If you wear a white coat and a tie, does that say it? Maybe, maybe not.
There are things that say the opposite, though, and those are the things to avoid. I'm actually going to come back to that later in the talk. So, but well said, yes. All right, well, let's move on. We're going to go on to number 2, profane man. A patient comes to the clinic. This is a patient you know. He's been in the clinic before. He's got back pain. And he says, my back is fucking killing me. You aren't doing anything. How can you just let me suffer? So, without going into the wrong response, we're going to talk by. Let's go back to empathy. Why did profane man act this way? Why did he come in, kind of get in my face a little bit and throw out, drop the F-bomb, look me in the eyes and whatnot? He's never done this before. Why is he doing now? Well, because that's what he has done his whole life. He's being profane and confrontational as a strategy that he's used successfully at his whole life. He's very good at it. He's used it in his professional relationships. He's used it in his family, and he effectively intimidates people, and he gets his way that way. It's nothing personal. He's not doing it because I'm me, or he'd do it with anybody who was there. This is just what he does to try to get his way. This is a quote that I love. This quote actually blew my mind when I heard it. I was working in the Ada County Jail, which is the jail in Boise. And Scott Elison was the psychiatrist there. He's also the psychiatrist for the Idaho DOC. But we were talking, and he just said, inmates are just like everyone else. They're just trying to get by as best they can. Well, this is how profane man gets by, as best he can. This is what he does to get by. So, here are the potential responses to profane man. So, number 1 is, he yelled at me, he used profanity with me. I give it right back to him. Who do you think you are? You can't talk to me like that. God damn it. I'm in charge here. You're not in charge here. Well, that doesn't work. That's not a good response, of course, for a couple of reasons. One, we want to develop a physician-patient relationship, and that response, not his initial, dropping the F-bomb on me, but that response made us enemies. Now we're adversaries. 2, he's done this his whole life. He's really good at it, and he likes it. I'm not good at this. I don't like it. I'm at a clear disadvantage here. 3, at the bottom, all clinical encounters are discussed back in the dorms. So he's going to go back to the dorm and say, hey, you know what just happened? I just got Keller's goat. And then I guarantee you it will breed other people to come and drop the F-bomb, because it's shown to be an effective strategy. Okay, what's the second thing we could potentially do? The second thing is bargain. Now calm down. I'm sure we can work something out. I'm sure that this person has heard that one before on the outside. Well, same thing. He's won in that case. All clinical encounters are discussed back in the dorm. Hey, if you get in Keller's face, he's going to fold, he's just going to fold up, and you can get whatever you want from him. You want more gabapentin, just go and drop the F-bomb on him and look at him hard in the eye, and you'll get it. And number 3 is give in. What is it you want? I'll give you whatever you want. Of course, none of those are the correct strategy. All clinical encounters are discussed back in the dorms. If you use any of these, you're going to see more of it. So these are entirely, all of them, counterproductive to the goal of creating a patient-doctor relationship. So what is the correct response? the correct response, oh, I should tell you before I get to that, I started my career as an ER doc. I kind of learned what the correct response is actually in the ER and then going to the jail, because when I was in the ER, people swore at me a lot. Matter of fact, much more than in the jails. There is more swearing at the doctor in ERs than there is in the jail. There's more in-your-face confrontations in an ER than there is in the jail. And in the ER, I couldn't do much about it other than say, please stop, please don't swear at me, in which case they just would swear more. And it might not have even been my patient. It might have been his family. You know, you're not going to admit grandma to the hospital. Well, blah, blah, blah.
Hey, but keeping everyone connected is, and tracking deliveries has been AT&T. You find the best 5G plan for your employees, so growing your
Jeff, you're on mute.
There we go. Now I can unmute myself. I couldn't do much about profanity other than ask the patient to stop. But jails and prisons, I discovered once I'd been there, are different. Jails are much better than ERs in enforcing boundaries, and that's where we're going to come up with here. For one thing, in the ER, when I was in the ER, we had security in quotes, who was a guy about my age, mid-60s, you know, and he couldn't run very fast, and he didn't look very intimidating, and he certainly wasn't wearing a gun or a taser. And he wasn't very close. So if you called for him, if you called for him, it might be 20 minutes before he got there. But in the jail, deputies were always nearby. They're always nearby. They weren't usually in right next to me, but they were. If someone got in my face, they knew about it and they were nearby. I could always call them. In a jail, I found out there are actually fewer intoxicated patients. You will see intoxicated people in a prison and jail, but not as many as in an ER. There are fewer weapons in a jail and prison. I'm not saying there are no weapons in a jail or prison, but there are fewer than show up in an ER. In an ER, I've seen guns and knives and all sorts of things. In a jail, patients who behave badly are disciplined, or they are disciplined and they know they're going to be disciplined. In an ER, that doesn't happen. There is no discipline for that other than, stop it. And finally, the single most important difference is the last one. This is the take-home message. If you remember only one thing from this slide, it's this one: jail patients never go home. One reason I had to put up with swearing and bad behavior in an ER is because that was my only chance to see them, right? So if they are acting out because they have a brain tumor, I got to find that out before I send them out the door. I can't just kick them out. I got to find this out first. So I got to tolerate. But jail patients, and they may never ever come back in an ER, but jail patients never go home. They just go down the hall. So because of that, you can enforce boundaries with profane guy. And so the correct response with the guy who comes in and swears at you is to have a boundary. One is you can't show any emotion. Once again, emotion. He says, you are a MF. No emotion. It didn't hurt me, Everything's discussed back in the dorm. So if you react, oh no, not those words, they're going to go back to the dorm and say, hey, this really gets his goat. No anger, no nothing. If you can do it, just a flat face, nothing. Poker face. You say what the boundary is. I don't allow my patients to swear at me. And then you invoke the principle that you have security at your back, and they're just going down the hall, and you just say, we're done for today. Go back to your dorm. You don't ask. Go back to your dorm, and you don't have to enforce this. Your correctional officer will. I will see you again and then you say something, a couple hours tomorrow. We'll talk then after you've calmed down. And of course, you have to keep your word and see him again when you said you would. By doing this, I can tell you, having done this literally hundreds of times, that 99% of the time they come back, they don't swear. Oftentimes they apologize. I'd say 50% of the time they apologize. But they don't swear, they sit down and they've calmed down and you have your conversation. So remember that all clinical encounters are discussed back in the dorm. This works to my advantage here. Profane guy's going to go back is, hey, there's no, I just swore at Keller and he sent me back to the dorm and I'm really angry about that and I'll see him in a couple, but everybody else knows, hey, that isn't going to work. I'm not going to do it. You do this and people, this kind of behavior will happen less. So boundaries. So this is how you enforce boundaries, is what I just said. That's a verbal jiu-jitsu attack. A verbal jiu-jitsu technique about enforcing boundaries. And there are all sorts of boundaries that you should have and you should enforce. One is swearing. You should have a boundary for swearing. My personal one is this. I will allow someone to swear in front of me if it's not at me. I never allow someone to swear at me. If someone says you are a whatever, they're done. Clinic's over. You go back to your dorm. I'll see you later. If I don't know, let's say I'm shooting them with a knee, I'm doing something painful and they say, damn it. Then I'll say, please don't swear. And I'll give them one chance. And if they swear again, I'm going to say, we're done and go back to your dorm. That's my personal, you can come up with your other one. But I should say that this is also something that everybody who practices in that institution should really sit down. Everybody should have the same boundaries. You shouldn't have one person you can swear in front of, and it doesn't matter, and another one you can't. Another boundary is clothing. So I've seen just about every kind, just like you guys have, who are practicing corrections, every kind of, go to the edge of whatever the boundary is, clothing, not wearing their scrub top and their, I've had men come down shirtless. I've had women come down in their bras. I've had both of them with the pants down halfway. So anyway, so you should have a boundary about clothing. You should have a boundary about never being alone with a patient, especially one of the opposite sex. All medical professionals should have the same boundaries, and you can make your own boundary, but you need to have boundaries. Now, one thing about, and you need to be able to enforce them just the way the technique that we've just talked about. One thing, though, about boundaries is that you have to conform to your own boundaries. So I have seen people, more than one, I'm sure you have too, who think, well, the inmates have, the incarcerated people have, they swear a lot. So if I swear a lot, they're going to accept me as one of the gang and I'll have a better relationship with them. It does not work that way. They will not respect you. And everything's discussed back in the dorm, and they're going to go back and say, this guy wants to be part of us, and it doesn't work. So you can't swear. I have to admit that that I occasionally swear out when I'm not at work, but if I'm in the jail, I do not swear, and not even if there are patients in the room. I don't swear in front of the correctional officers either, the deputies. I just don't. You have to conform to your own boundaries. Clothing. You have to form your own clothing boundaries here too. And we go back to being dressed like a professional. So one of my things that happened to me that brought this home is when my jail business employed nurses. And I remember the jail commander who called me and said, will you please tell your nurse who's passing meds to wear a bra? She wasn't wearing a bra, and it was very evident both to the deputies but also to the inmates. You have to dress like a professional. You have to conform to your own boundaries. Being alone with a patient, I have got a call from a sheriff once that said, your employee is no longer welcome in the jail. He's a good employee. Well, why not? He was alone with a female inmate. Well, it turns out that he was, I don't know, counseling her because she felt sad. But they were in a dorm, they were in a stairwell, not medical. And it was a bad situation. And you enforce your own boundaries. If that's your boundary, that a patient can't be alone with you, then you can't be alone with a patient. All clinical encounters are discussed back in the dorm. If you cross your own boundaries, or if you allow even one patient to cross your boundaries, everyone else in the dorm and the whole facility will know. Okay, so this is a summary. Look and act like a doctor. Treat incarcerated patients like any other patient. Don't label your patients. Have empathy, understand why your patients are acting the way they do, and enforce boundaries. Now, that's what we've covered so far in 2 cases. Those were actually the easy cases. We're going to tackle the difficult patient encounter cases in part 2, which is Wednesday, December 6th at 6:30. So I see that Steve, it's time for question and answers, and Steve has his hand up.
Thank you. I know there's some way to do electronic hands, but I don't know how to do that. So, Jeff, we've talked about this a lot between ourselves and at other times and other places. And I think that part of what you've said in the last slide can be summed up in the fact that what you and I, and what we want to try and do is not only be professional ourselves, but make the entire encounter a professional encounter, so that we're asking that the patient act like it's a professional encounter, not swearing, because that gets in the way of communication, behaving properly, dressing properly, and that the whole process, our clinic, ourselves, our nursing staff, we are a professional organization of caregivers, and we expect the same from them. And we are also teaching them, hopefully, how to behave in that respectful situation. So you're going to look and act like a doctor. You're going to treat your patients like other patients. You're going to ask them to treat you as a doctor, and your staff as doctors. Is that, that's what we've said before, and I think you're saying that again. And it's not just only the patient, but I think that the whole milieu, the clinic, everybody in it, we're presenting a professional, respectful, competent image.
Oh, well put. Yes, I think that is very well put. And if you expect your patients to act in an appropriate manner for a medical clinic, they will, almost always. And it's a matter of expectation, but they will reflect back what you present to them. So as Steve said, you have to present yourself as a professional and enforce the boundaries that where they also fulfill their part of the bargain and act like a patient, a patient. Anyone else? Mike, I'm going to call on you. You're going to be the referee of who gets to speak. I can't see.
Yeah, I think just speak up, and because I can't see all of you at the same time either.
Okay. Of
Jeff,
course, the other thing, Jeff, is that we have to enforce it, but we also have to inform and then enforce.
Correct. You have to tell them, and that's why I mentioned that briefly, but it's worth emphasis. You have to tell them what the boundary is. I don't accept swearing at me in my clinic, so go back to the dorm. I'll see you again later. I think Michael was gonna add his hand
Michael
up.
Nikke.
Hi, Jeff. Thank you so much for the talk. It's very relevant. I want to say that I more than agree with your ER versus jail encounter, because I also, like you, work in a both environment. Frankly, I had a couple of ER calls that were very close calls because the environment of ER is never prepared or designed to accept individuals that are coming in already mad about their interaction with law enforcement or anyone else. And maybe there are also, we have had a couple of cases where there were severe psychiatric issues, and one of them actually jumped on my nurse last year and almost killed her, broke her vertebrae. And if it wasn't for a couple of other guys and one law enforcement officer that was around, this gentleman was so big that he fell on, 300-pound versus a 140-pound nurse, and broke a couple of her vertebrae in a lower lumbar and almost choked her to death. So we have had a lot of these violence happening, and that's because exactly what you said. You can't rely on your individuals who are security guards around there. You can't rely on the interaction that they have had on the initial phase of their arrest by law enforcement. And it needs to be a calming, soothing interactions by the physicians and medical providers to just calm down the situations. Otherwise, it basically escalates and goes down the drain. I would say I definitely agree with all the comments about the dress code, and it does make a big difference. But I think that one of the commentaries was about really putting it down, like separating yourself from the custody. That I'm here to take care of you. If you are ready for it, I'll be more than happy to do so. If you're not ready, we can get together later. And that's how I interact with them. Like if they're angry or upset, I just, okay, well, we're not getting anywhere. When you feel like it, just let me know immediately. I'll see you.
Very good.
Yeah.
Yes. Excellent.
Yeah, I was going to say that pretty much the same thing, or along the lines of when something really dysfunctional is going on in the encounter, either with me because I'm reacting, or with them because my patient is being belligerent, difficult, whatever it is, swearing at me, whatever it is. Look, it doesn't sound like you have an emergency today. I'm going to let you go back to the dorm and chill out, and I'll reschedule you the next time I'm in the office. But this isn't working for either of us. And I found that technique really, really worked. And the other thing that I did often enough with a patient I've never met before, if I'm sitting at my desk and he's called into my office, I'll stand and offer to shake his hand and introduce myself. And I think this standing up from your desk and as a show that you respect him, her, is an important piece to start a new patient relationship, and something that I always used to do.
We're not allowed to shake hands in a prison.
Some people are not. You're not allowed to shake it. You're not allowed to do that.
Not in the
No.
prison, not in our prison, no. No.
Actually,
Well,
It was like that too.
We do a fist
No,
bump sometimes, but we're not allowed to shake hands.
There are a lot of other ways to show someone
Yeah.
yeah.
that
Yeah, I agree. Yeah.
you respect them as that you recognize they are a human being.
Yeah, so I do a lot of OMM. I don't know if you guys know osteopathic manipulative treatment for my patients, and so I think I'm on a different level, I guess, at my institutions, because they allow me to do whatever I can to basically take care of the business, take care of
Yeah.
my patients.
Right.
I we're touching our patients in the most intimate of all possible human interactions in some time in some stand, and so I certainly never had anybody question me standing in my office and offering a handshake.
We're allowed to
This is
examine.
pre-COVID. It was pre-COVID. Well, it's nothing to argue about because
Yeah.
some places won't allow it. I have to disagree respectfully, but that's
Right.
okay. I mean, we undoubtedly are privy to the most intimate of all touch in a prison as doctors. You know, that's the way it is. But I've heard that before, and that's one of the reasons I brought it up, honestly.
We can examine and even some docs can do manipulations, but for some reason their policy is you don't shake hands. That's just their policy. No, they don't have.
Shaking hands doesn't make you a good guy. I've shaken hands with a lot of people that I would trust with my lunch.
I agree. And this is pre-COVID, and things have changed even on that.
Some correctional officers view it as a way that you could pass contraband from yourself to an inmate
Something that I
versus
hadn't thought
Well,
about.
that's the reason.
doing a physical exam.
Jeff, when you talked about when a patient discusses you, I think that that's in the wheelhouse of taking care of ourselves when we acknowledge the emotions. I agree. You can't show it. You can't. You have to hide those emotions away. But we have to be healthy with ourselves. That's actually how this whole wellness thing that we're going to do in 2 weeks started with having self-knowledge enough when we're in a patient encounter to understand that sometimes we can have reactions to situations and people. That's just the way it is.
Well, yeah, so we have, we all have patients who are notorious, and we all have patients who are dangerous, and we have patients who are provocative, and we have patients who are, bonding. We're going to talk about that. I'm going to talk about that a little more the next time. But you can't have a reaction. It's better if you don't have a reaction to any of it. None of it affects you. So,
Jeff, if you were to compare your situation in ER than jail, would you say which one would you say actually it's much easier to interact with the patient?
jails are way easier.
I totally agree.
Patients. One is that they're they're not intoxicated as often, not even close to as often. Anyway, but I actually went through all of that. There's a consequence for acting bad. You've got a deputy right there and they know it. Anyway, it's just an easier place if you you're dealt a good hand. So you've got to use the cards you're dealt wisely. Seeing no more questions, we're about close to ending time. I want to thank everybody for coming, and we'd like to grow this grand rounds to something big and special. And y'all are helping, so I appreciate that. Thanks, everybody.